as we get closer to the end, which is about 7 o'clock, would the people, Annie Schnuber, come down and be close? You're next with James Klein. Yes.
Good afternoon. My name is Stephen Hans, and I have the privilege of serving as Vice President and Counsel for the New York State Health Facilities Association and the New York State Center for Assisted Living. Joining me today is Deanna Stevenson, Director of Managed Programs for the New York State Health Facilities Association and the New York State Center for Assisted Living. NYSHFA and NISCAL members and their 70,000 employees provide essential long-term care to over 44,000 elderly, frail, and physically challenged women, men, and children at over 350 skilled nursing and assisted living facilities throughout New York State. As we sit here today, New York's long-term care and assisted living providers face significant challenges as a result of the state's transition to manage long-term care, recent state budget constraints, and certain initiatives proposed in the 2016-2017 executive budget. Over the past 9 years, funding cuts to New York's long-term health care sector have exceeded $1.7 billion. Initiatives implemented by the MRT have resulted in approximately $700 million in cuts over the past 3 fiscal years, and the potential for additional federal Medicare cuts only exacerbates New York's already fragile long-term care finances. For example, at $48.43 per patient per day, New York unfortunately has the nation's second largest shortfall between Medicaid payment rates and the cost of providing necessary care. As providers enter their 8th year without a trend factor for inflation, New York's long-term care facilities have worked hard to endure these past budget cuts, and this is demonstrated by the fact that nursing home spending is often below the Medicaid global spending cap enacted under the MRT. Recognizing these constraints, it is very important to note that the 2014-2015 enacted budget eliminated the MRT-imposed 2% across-the-board provider rate cut for nursing homes, which was effective April 1st, 2014. This initiative would have restored $280 million to long-term care providers throughout New York State over the past 2 fiscal years. However, the state has yet to enact the approved restoration of these needed monies. With these issues and constraints serving as a backdrop, we would like to briefly address 3 areas of concern with regard to the 2016-2017 executive budget. First, the impact of the proposed minimum wage increase on long-term care and assisted living providers. And Deanna will discuss issues concerning the state's transition to manage long-term care. And finally, I'll raise 3 issues that NYSHFA and NISCAL respectfully request be included within the 2016-2017 enacted budget. Turning first to the minimum wage. First, I would like to thank Senator Young, Senator Hannan, Senator Rivera, Senator Vino, and the committee in general for the recognition of the impact that the state's minimum wage has on New York's health care providers. You may be familiar with the assertion that a rising tide lifts all boats with regard to increasing the minimum wage. Certain economists view this assertion as true for those businesses and employers who are able to pass the increased labor costs through to higher prices for their products or services to the end consumer. However, this assertion is not true for the state's Medicaid providers who provide essential long-term care to New York's most frail and infirm individuals. This is true because there's one major problem. As you've heard today, providers of long-term care and the patients we serve are almost completely dependent on government programs for the payment of necessary care. As such, while other boats may be lifted with the tide, New York's skilled nursing and assisted living providers are not able to pass through the increased labor costs of an increase in minimum wage as a consequence of being tethered to the anchor of Medicaid, if you will. It has been said that to care for those who once cared for us is one of life's highest honors. Nowhere is this more evident than in New York State's nursing homes. And our residents are often discharged from hospital settings needing extensive care and rehabilitation. In addition to stroke patients, ventilator-dependent patients, cancer patients, dementia patients, TBI patients, and other high acuity patients, a majority of our residents need considerable assistance with their activities of daily living. Caring for our residents is a challenging privilege that requires training expertise, patience, and resources. Presently, 76% of all nursing home residents throughout the state of New York rely on Medicaid to pay for their care. Another 13% of our residents rely on Medicare to pay for their care. Consequently, nursing home and assisted living providers face a unique and difficult position. First, we cannot simply raise the price of our services to reflect higher labor costs due to an increase in the minimum wage. Second, we do not have the ability to change the makeup of our patient mix or shift costs to other residents. And third, we are not willing or able to reduce the needed services or the quality of the care we provide. Working collaboratively with other statewide associations representing nursing homes, hospitals, and home care providers, and utilizing the best currently available data, NISHPA conservatively estimates the executive's minimum wage proposal would increase costs for skilled nursing providers by $600 million and more than $50 million annually for assisted living providers. These figures were established employing a methodology that you heard earlier with regard to direct impacts, wage compression, and indirect labor costs. Given the significant costs associated with the proposed minimum wage increase from $9 to $15 an hour, coupled with the unique inability of nursing and assisted home providers to raise the price of our services to absorb any mandated increase, it is vital that the state fully fund the increased labor costs resulting from the implementation of any minimum wage increase. Quite simply, the proposed minimum wage increase places skilled nursing providers in a uniquely detrimental situation. We are dependent upon state and federal funding for payments of almost 90% of our residents. These payments already do not meet the cost of providing care at the state's current minimum wage level. As other states have done when increasing the minimum wage, New York must financially acknowledge the unique nature of skilled nursing and assisted living providers and fully fund this increase in a manner that does not impact the Medicaid global cap to ensure the continuation of access to high-quality long-term care. I will now turn the mic over to Deanna Stevenson.
Good afternoon, everyone.
Good afternoon.
In regards to managed long-term care, I want to talk about three distinct pieces today. The first one I want to discuss is the extension of the nursing home benchmark rate. In 2015, the state established a benchmark rate that would be paid by managed long-term care plans to be contracted to skilled nursing facilities for a 3-year period. Generally speaking, the benchmark rate is the current fee-for-service Medicaid rate and is set to sunset on 2018. In establishing the benchmark rate, the state acknowledged that it will assess the impact of its long-term care managed care policies and consider extending the benchmark rate beyond that 3-year requirement. The benchmark rate provides vital rate stabilization and has secured the capital rate component necessary to fund needed facility renovations in order to optimize our residents' care. As such, the benchmark rate has served to provide a level of certainty to providers that will be necessary for the program to continue beyond the rate's sunset date. A stabilized Medicaid benchmark rate will also add to a provider's ability to commit to the fully integrated Duals Advantage, which is our FIDA initiative, which coordinates resident care between the state and federal governments. Secondly, health plan solvency. Stabilizing resident care rates through the benchmark rate not only benefits providers and the residents we serve, but it also benefits managed care plans by ensuring that premiums will be sufficient to serve our most vulnerable population. At the start of the state's transition to managed care, long-term care, there were approximately 45 managed long-term care providers. Throughout 2015, we witnessed the failure, reformation, and collaboration of many of these plans. Earlier in 2015, as you had heard before, HHH Choices Health Plan filed for bankruptcy, leaving behind creditors including nursing home providers. One example is we had a provider that is standing in waiting for a $500,000 payment. Consequently, increased scrutiny by the state as to the financial health of long-term care managed plans is needed to protect both the consumers and providers. Lastly, eligibility determinations. It is the state's policy that individuals not enrolled in an MCO or newly eligible individuals in need of nursing home care will need to obtain eligibility through their local service district. Under the state's policy, local districts have 45 days at present from the date of a completed Medicaid application to determine eligibility. To date, there are numerous documented reports of counties failing to meet the required timeline of those 45 days, therefore jeopardizing necessary payments for nursing home care. If these extended eligibility timeframes continue, the goals that you heard this morning from Jason of the state's long-term care managed care initiative will not be achieved, as enrollment of these numbers will be greatly reduced. At this point, I'm going to turn it back to Stephen.
In the interest of time, I'm going to summarize very quickly on the last remaining items. One is the one that the New York State Senate has included in their one-house budget with regard to the return on equity, something that was taken away in the MRT from proprietary nursing homes. We respectfully asked for the legislature to include that in the 2016-2017 enacted budget. Secondly, we would respectfully request that the legislature include an increase through the SSI rate for adult care facilities. New York has not increased the state portion of the supplemental security income rate for low-income elderly and disabled individuals in adult care facilities in 8 years. The current $40 per day is clearly insufficient to provide room, board, meals, activities, case management, supervision, and medication assistance for our SSI residents. And lastly, the issue we would like to also included within the 2016-2017 budget will be an assisted living program rate increase. Assisted living facility Medicaid rates under the ALP program are based on 1992 costs, receiving only minimum inflationary trend adjustments through 2007. And since 2007, like skilled nursing facilities, assisted living facilities have not received any inflationary trend factor adjustments to their rates. Thank you very much for your consideration.
Question?
Senator Krueger has a question.
Thank you. Just a clarification. In the beginning of your testimony, you talk about your facilities on average receiving $50 a day per patient from Medicaid?
No, what that is, the cost, that is, there's a national study that goes through all the states in terms of the cost to care for a Medicaid resident. And right now, the amount that we are reimbursed, nursing home providers throughout New York State are reimbursed, falls $48 short of the full amount necessary to care for those residents.
Okay. So you would agree that in New York State, Medicaid is paying more like a minimum average of $300 a day, close in certain parts of the state, close to $400 a day.
The average, to the best of my knowledge, in New York State's actually down towards $200. In some places, it's well below that.
Okay.
But the average for New York State, when you take all the Medicaid rates, you know, from Montauk to Buffalo, in terms of what is that state average, it falls $48 short of the provision of care for that resident. Even
though most states don't cover nearly as much long-term care under its Medicaid program as we do?
That was a decision of the Department of Health in terms of the population that is covered.
Okay. No, because I was looking up the state's charts, and I suggest you double check, because I think their numbers for nursing homes are around the 320 to 380 mark. I didn't see any regions where it's falling. In terms of a Medicaid
reimbursement, I would not say upstate. That's absolutely not true. And even downstate, I think the average is well below.
So take a look at their charts, because I think we're working off some different numbers.
Sure.
And I think
no, and I'd be happy to get you.
We can agree and disagree, but I think New York State ends up paying more towards long-term care in our Medicaid program than anywhere by a pretty hefty increase, by a pretty hefty amount.
That may be accurate, but I still think for the provision of care, Senator, that there is a full shortfall. I mean, that is an accurate number, and I will get you that report.
Thank you.
Thank you.
Thank you.
Thank you for your input.
Leading Age New York, Amy Schnurber, Vice President Advocacy and Public Policy, with James W. Klein, Jr., President and CEO. Next will be Community Healthcare Association.
So thank you for having me. We don't have Jim Klein with us today. It'll just be me. And I appreciate this opportunity to present testimony on the health and Medicaid components of this year's budget. My name is Amy Schnauber. I represent Leading Age New York, and we represent nonprofit aging services providers, long-term and post-acute care providers, all the way from independent senior housing to home care, assisted living, managed long-term care, nursing homes, continuing care retirement communities, and other retirement communities. So we have an interesting perspective since we represent the entire continuum, and we found that a lot of our members also represent an entire continuum of providers on a campus setting. And I would say the biggest challenge we have is that there hasn't been a lot of thought into what we're going to do with long-term care. I can tell you that by 2025, you will see, I'm not reading all my testimony, don't worry about that. By 2025, the state's population, we will have 18% of the state's population will be in their 80s. Unfortunately, this budget and past experience has not provided any real investment in long-term care. And if you look on page 3 of your testimony, you will see an answer to the question that Assemblyman Gottfried asked of Jason Helgerson today and the commissioner, which was how much of the district money is going to non-acute care providers. So how much of that money is going to anyone other than a physician or a hospital, and you will see from that pie chart that it is a very small fraction. It's on page 3 of the testimony. The fact is the money is not trickling down. Trickle-down economics is not working for long-term care providers, I'll tell you that. This budget doesn't improve that situation. You may recall that last year's you included residential health care facilities in the Essential Health Care Provider Grant Program. However, when it was ultimately implemented by the Department of Health, they limited it to hospitals and hospital-based nursing homes and said that nursing homes were not included because they were not hospitals. We then looked at the Nonprofit Infrastructure Capital Investment Grant Program that you also enacted, and in this case, nursing homes were also excluded because we are hospitals. Because Article 28 hospitals include general hospitals and nursing homes. So if you say hospitals, it includes us, but if you say general hospitals, it does not. So in both cases, they excluded us. So we're again at a point where none of this investment, whether it's from IT or any infrastructure, is really going to long-term care. And the fact is we're not going to be prepared. We have e-prescribing. Someone talked about the I-STOP provisions a little bit earlier with OMIG. We still have providers who are struggling to meet that March 27th deadline because they simply don't have the resources to put these IT systems in place that are required. The great news this year is that the department has decided that the waivers could go beyond just the physicians and it could actually be for settings. So many of our members are looking into that. But the reality is that if we don't find resources for long-term care providers, we're not going to move in the direction that we want to. And so what we're asking for is $100 million in funding that would specifically be directed to long-term post-acute care providers, because if you don't line it out for us, it is clear that our members are not going to get it. The other place of significant concern for long-term care providers is the Medicaid rates for managed long-term care. They are woefully inadequate. We are now working on 2-year-old rates. As Jason Helgerson said, there's a whole number of rates that are waiting on CMS approval. But what it has meant over these last couple of years is all these additional mandates and these new populations that are going into managed long-term care are simply not accounted for in the rate. And as you will also see, we included a couple other charts on page 5 and page 6, in which we see that the aggregate premium margin of managed long-term care plans has plummeted from a positive 3% in 2012 to a negative 4% for the fourth quarter of 2014. So, once these rates get approved through CMS, we still have a lot of ground to cover because we've been negative for so long. And I would say that if we can't start turning that picture around, the plan of putting all these folks into managed long-term care and transforming the long-term care system is just not going to happen. We have too many plans who are in the negative, and they're not going to be able to survive. And I think that, you have a situation where if you might want some consolidation, but no two providers who are in the negative are going to be in the positive by merging. So I think that we have a real issue that we're asking for the legislature to address. We are actually asking for you to reject the governor's $22 million in cuts to managed long-term care plans. And in addition, we're asking for an increase of $90 million to help sustain the managed long-term care plans. The other proposal impacting managed long-term care plans, adult day health care, and nursing homes relates to the transportation carve-out. You may recall that this is a provision that the governor included last year for managed long-term care. He is now, and you saw fit to include statutory language that would ensure that managed long-term care could be carved out of the state operator for transportation. We would like to see it reestablished in this budget. We would like to also include adult day health care and nursing home rates. I think that what the executive is failing to understand is the amount of care that it takes for these plans and providers to transport individuals. These are people with very high acuity levels. They're people who would be qualified for nursing home level of care. And just getting them from their home onto a van and to where they need to get it takes a lot of work. Sometimes it includes shoveling their sidewalk. And so we're just concerned about what that would mean in terms of time for them to get to their programs. The other thing I would say is that we have a whole number of managed long-term care providers and other providers who have spent significant money over the last year or two to put transportation fleets together, and now they're being told that those won't be funded any longer. We think that's the wrong direction. You'll see that my testimony includes pieces on minimum wage and the Fair Labor Standards Act. You heard from the Hospital Association, NISHVA, and HCP. We worked on those numbers together. It's a significant impact. We would, our providers would love to pay increased rates to their staff, but when your pay or 70% of your income comes from Medicaid, there's no way you can do that without an increase in Medicaid funding. So we would ask that any increase that you put there, you fund. But I'd also say that we're in very dangerous territory when you have certain workers getting a higher minimum wage, because our members are going to have to compete for those workers anyway. So we're going to have areas of the state where you can get $15 by working for fast food, but you won't be able to you'll only be able to make $10 an hour caring for somebody. Those are very hands-on jobs. It's a lot of hard work. It's hard to imagine how you're going to get quality workers under those conditions. The final areas I would like to talk about are two components of aging services that I think are important for the state to consider, is adult care facilities, assisted living program, and independent senior housing. The fact is, if we can keep these people in the community and in these settings longer, we're going to be able to keep them from moving to a nursing home level of care at a much higher cost to Medicaid. We know that in some parts of the state, because the SSI rate is so low, the last increase was 8 years ago, we have areas of the state where the adult care facilities are prepared to close down. And in some counties, they're the only ACF. That will mean that those individuals will have to go to a nursing home because there's nowhere else they can go. We have to find a way to invest in these settings. The other thing I would mention is a resident advisor program that we would like to see Medicaid fund. Senator Young is, I'm sure, very familiar with the Smartmans that are in Jamestown in her district. And what we found is that these apartments provide a great platform for care. And if we can keep people in independent senior housing and provide some very light touch services, we know that we can keep them from going to Medicaid. Many of these individuals, if they're on SSI, if they're in low-income housing, they truly are one event from being a high Medicaid user. There's significant savings if we can keep them in independent senior housing. But the only way we're going to do that is if we increase funding for independent housing. There's a great program in Syracuse where Christopher Communities is working with a PACE program, and they co-locate some services. Again, this is a huge benefit to the community. It's keeping people in independent housing and keeping them from going to nursing homes. So if we can replicate the SmartMints that are in Jamestown, or if we can be replicating the program that Christopher Communities is offering in Syracuse, we are going to keep people in the community longer at great savings to Medicaid.
Thank you, Vice
So,
President
you're welcome.
Schnauber. No questions, so we appreciate your participation
Okay.
today.
Thanks.
Thank you. Our next speaker is Beverly Grossman, Senior Policy Advisor from Community Healthcare Association of New York State. Welcome.
We gave you 50 copies. From Chicane's Healthcare Association of New York State. They lost my testimony. Let's hope that's not personal.
I'm sorry.
So you got it? Okay, so I'm going to go ahead? Okay. Thank you. You ready?
Go ahead.
Okay. Thank you for the opportunity to provide testimony today on the Governor's 2016-17 budget proposal. My name is Beverly Grossman, and I am the Senior Policy Director of the Community Healthcare Association of New York State, Chicane's. We are the state's primary care association for federally qualified health centers. We serve as the voice of community health centers and as leading providers of primary care in New York State. We work closely with more than 60 federally qualified health centers, FQHCs, that operate over 600 sites statewide and serve more than 1 million patients annually. We're not-for-profit, community-run health centers located in medically underserved areas that provide high-quality, cost-effective primary care to anyone seeking it, regardless of their insurance status or ability to pay. The most pressing issue currently affecting FQHCs is a $54.4 million funding deficit in our indigent care reimbursement. The Diagnostic and Treatment Center Uncompensated Care Pool, DNTC, UCP, has historically been comprised of $54.4 million in state funding with an equal federal match, totaling $108 million. Although this funding does not fully reimburse FQHCs for the cost of providing care for the uninsured, it is essential to ensuring that FQHCs are able to do so, a cornerstone of our mandate. While we are pleased that the executive budget includes the state share of the $54.4, the authorization for the federal match expired in 2014, and as to today, FQHCs still have not received more than half of their 2015 indigent care funding. The Department of Health requested the federal match to be reauthorized and extended, but we have yet to get an approval. FQHCs are already beginning to feel the effect of not receiving the full 2015 indigent care funding amount and have begun reducing staff, delaying expansion plans, limiting clinic hours, and making plans to reduce care such as oral and behavioral health services, canceling OB and women's health services, and so on. Nearly 25% of health centers that receive indigent care funds are experiencing operational deficits and will continue to do so if they do not receive 2015 federal match dollars. In order to address this critical funding deficit, we urge the legislature to include $54 million in contingency funding to fill the gap created by the loss of federal dollars to ensure that FQHCs are able to continue to provide high-quality, community-based primary care to all New Yorkers. New York's stated priority is to transform the healthcare system by providing access to high-quality, coordinated care through the integration of primary care and other community-based care. However, downstream community providers have yet to receive any meaningful funding under DSRIP compared to the total percentage of dollars available to PPS leads. Furthermore, in last year's budget, non-hospital community-based healthcare providers received less than 4% of the nearly $1.7 billion in new healthcare funding. New York State is relying on the work of community-based healthcare providers to transform the state's healthcare delivery system, yet has not made the equitable investment in the sector to support this work. The state should make the following investments in community healthcare providers to support their integral role in transformative initiatives. Allocate 25% of the $195 million in healthcare facility transformation funding for community healthcare providers. Chicanes is pleased that the governor's executive budget proposes restructuring the $200 million of the healthcare facility transformation program appropriated in last year's budget and making $195 million of that available to healthcare providers for facility transformation. The inclusion of this funding is a heartening first step, although the funding must be available to all types of providers participating in the transformation efforts, not just hospitals and acute care settings. Additionally, Chicanes requests that a minimum of 25% of the $195 million, or approximately $49 million, be allocated solely to community health care providers in order to ensure that community health care providers have equitable access to these funds. We also asked the legislature to create an essential community health care provider pool. Last year's budget included $355 million for Essential Health Care Provider Fund to support provider transformation initiatives. However, community health care providers had no access to this money, despite their essential role in the state's transformation initiatives. Chicanes requests a new $88.5 million funding pool, the Essential Community Health Care Provider Fund, be established and make available solely for community health care providers. This pool would have the same purpose as the pool in last year's budget, to support capital and working capital needs of community health care providers in the furtherance of health care transformation. In addition to the above funding requests, Chicanes also asks to add $20 million to the Community Health Care Revolving Capital Fund and ensure that last year's $19.5 million previously appropriated dollars are sent out in a timely manner. Fully restore funding for health centers serving migrant and seasonal farm workers to previous fiscal years. Support doctors across New York and provide additional support for school-based health centers to account for the upcoming transition to managed care. In conclusion, Chicanes supports New York's healthcare transformation efforts and is pleased the state has recognized the importance of expanding access to comprehensive community-based care. However, meaningful, sustainable delivery system transformation will only be achieved if the state provides appropriate financial investment directly to the community health care providers whose work is at the center of this reimagined care delivery system. Chicanes stands ready to work with the governor and the legislature to support New York's ambitious health care agenda. I thank you for the opportunity to present, and I'm happy to answer any questions.
Thank you very much. Questions?
Senator Rivera.
Hello. I just have a quick one. On page 2, we were talking about the FQHCs. They're currently, I'm going to just quote here. FQHCs are currently experiencing a $54.4 million funding deficit, in addition to the prospect of additional costs. There's numerous factors. So the transition of value-based payment, closure of Health Republic, and proposed minimum wage increase, that refers to future deficits, not the $54.4 million?